Hello, I'm Dr. Howard Hochster from the Yale Cancer Center, and today we're talking about the Oncotype DX colon cancer assay. We are going to be speaking about the development of the assay and its validation. And with me are two colleagues today, Dr. Darren Wheeler and Dr. Deborah Nagle.
Hi, I'm Dr. Darren Wheeler. I'm the West Regional Anatomic Pathology Director for Quest Diagnostics.
Hello, I'm Deborah Nagle, and I'm the Chief of Colon and Rectal Surgery at Beth Israel Deaconess Medical Center in Boston.
So we already discussed staging for colorectal cancer and the problem of prognostication in stage 2, how some patients are going to recur, and it would be really nice if we had a better handle on how to predict which those patients would be, the real need for personalization. And one of the tests that can help in personalizing the risk assessment for stage 2 colorectal cancer is the Oncotype DX colon cancer assay. You've worked with this, Dr. Wheeler.
Yeah, so as you said, we've talked about a number of histopathologic features mentioned in the NCCN guidelines that we use as pathologists to help kind of guide treatment. And obviously, none of them are we accurate and consistent with enough to be able to use any one histopathologic feature. So it's nice to have some kind of molecular analysis, and in this case a genomic signature, which can be paired up with the histopathologic features. And I think bringing the clinical, pathologic, and the genomic information together, I think we really can essentially divide up stage 2 patients into those that we lean towards adjuvant therapy and those we don't. You know, we mentioned that you have the MMR deficient patient, I think that we would not treat, the T4s that we would treat, and then now you're left with really essentially in the stage 2 category, the T3 N0 patients who are MMR proficient, and those that we can use a genomic signature to help give them a recurrence score that can help guide us as far as treatment. Not necessarily a magical score that's predictive, above which you would treat and that you wouldn't, but I think it's a very good guide as to which are going to be the more aggressive tumors, and much more accurate and reproducible than we can with histopathologic features alone.
So this is a gene expression test that can actually help quantitate the individual personalized risk of recurrence.
That's correct.
And how do you incorporate that into the kind of general workflow when you're dealing with processing colorectal cancer specimens?
So at our institution, what we do is when we're initially looking at a cancer resection, if it falls into that stage 2 category, we will have the MSI testing done, whether it be MSI testing or the mismatch repair immunohistochemistry, and we'll have that result. And if there are an MMR proficient stage 2 T3 patient, those we will send out to have the Oncotype DX assay performed. And although the pathology report will be issued at the time that we look at the cancer resection, within about 10 days, you'll have the result of the Oncotype DX assay to pair together, and the surgeon can use that for educational purposes as well with their patients, and then go on to the medical oncologist to decide how they're going to treat that patient.
We actually changed our workflow around the pathology specimens in order to accommodate a timely result from Oncotype. And so we do the same thing. We get the MSI done right away on the initial specimen once the pathologist identifies that it's node negative. And if it's stable, we send it out to Oncotype because, as you know, we want our patients on chemotherapy within 8 weeks of their resection.
Right. So you have it kind of as a reflex test for the mismatch repair enzyme proficient patients.
Exactly.
That's great. So the test is really a 12-gene expression, a profile that was selected from 700 plus genes in several data sets. Can you tell us a little bit more about how they came up with the test, Darren?
Well, I think in general, as you said, you start out with a large data set that shows, through literature review, that shows, prognosis in colon cancer. And then what you start to do is you start to figure out kind of a weighting for those genes. Obviously, a larger number of genes is not necessarily better. And then, through kind of analysis, you figure out, what gene set is just as powerful as, say, the larger original 700 gene set in kind of a smaller format. And as you said, it gets down to a 12-gene assay. And you go through the initial development phase, and then we had the validation, and now we have three different trials: the Quasar, CalGB 9581, and then more recently an SAB C7 trial that have all further validated the power of the test.
Right. Well, the Quasar trial was really the largest stage 2 colon cancer experience that was done really in the 80s in England, but it still has the most stage 2 patients in it and the best outcome data. So it was really very convenient that we could go back to that data set, get the tissues for most of the patients, and then try to use that for validation of the Oncotype score. That's how Genomic Health worked with the MRC in UK to come up with the validation. So when they went to validate the 12-gene signature in the Quasar trial from England, they looked at the recurrence score based on 3 different prognostic groups: greater than 40 for the recurrence score being high risk, 30 to 40 intermediate, and less than 30 being the low risk. And in fact, the recurrence score was quite prognostic for each of the groups. So that was kind of the first validation. And the CLGB 9581 was a really interesting trial. It was for patients who were considered to not be candidates for chemotherapy at the time when we were giving a lot more chemotherapy for stage 2. And they were randomized to an antibody that in the end was completely ineffective versus observation. So basically everybody got no treatment. But if you look at the demographics, it's a much better risk group. There are many more. The risk group for the 9581 is much lower than the standard conventional stage 2 patients. There were older patients. There were people who had fewer risk factors, and they actually showed that this test, even in a better prognosis group, came up with very similar results based on the recurrence score. So it turned out that in those two, and then also another NSABP trial, that you could really show that for the individual patient, the recurrence score was valid for predicting their risk of recurrence.
Yeah, and you mentioned the good prognosis group in the CalGB study, and I think it's really important to point out that here's a good prognosis group based on the clinical and the histopathologic features, and yet the genomic assay was able to identify patients that you actually wanted to be more aggressive with and get the adjuvant therapy. And so I think very important that we kind of highlight the fact that it really gives you, I think, a better, more accurate assessment of risk than we can just looking under the microscope.
Right. I mean, actually, when you look at it like that, that's quite true that the clinicians actually knew who were the lower risk patients, the ones who had more left-sided tumors, fewer right-sided tumors. They didn't really know about MSI high, but somehow they picked them out because there were more MSI high patients in that group compared to the other trials. But still, even within that, you're going to have the high-risk patients. So it's still, you can't tell it all by your clinical intuition, apparently.
Yeah, and that kind of leads into the clinical utility studies that we've been seeing coming out using this assay.
Right, which helps to inform practice to some degree because it's helping us it's giving us the tool to stratify the patients based on their likelihood of recurrence when we were a little bit at C before. The thing that I find interesting about the studies that have been done so far is that it actually shows a shift away from treatment in a lot of patients who are better understood to be truly low risk. And a lot of times in medicine we're predisposed to think that all tests mean more something. And here's a test that's actually leading us down a different algorithm for understanding who should be treated and not.
Right. There are 3 outcome tests, including a large experience from the Mayo Clinic and then another fairly large experience from an HMO in Israel, Clalit, that actually tested every single patient. And they had remarkably similar results that in general, once the physician got back the recurrence score for the patient, they tended to treat less heavily. The number of patients who had a downgrade in their treatment from either FOLFOX to 5-FU or from 5-FU to none was about 35%, and only 10% of the people went up in their treatment recommendation. So I guess as oncologists, we're a little bit prone to overtreat when we don't really know the specific personalized risk, but once we can get a handle on that, we seem to focus in better.
I think that more information just makes the clinician, any clinician, you or I, more comfortable recommending a specific treatment pathway and helps us dial back from things that we might be unclear on.
And worried about how the patient's going to do.
Right.
So we tend to kind of take the worst case scenario.
Right, we want to be as aggressive as possible because we want to cure as many people as possible, and it's nice to have some assurance that we may not have to do that for everybody.
I think as a trained physician, you now can kind of draw a line of what you consider a high-risk patient you're going to treat and those are not. So say it's going to be a 15% recurrence, that's where you're going to draw the line. If I tell you as a pathologist there's a focal lymphovascular invasion, or perhaps it's a poorly differentiated carcinoma that is microsatellite stable, I think it's hard to know where that line is is that alone good enough for me to treat? What is that recurrence risk? What am I going to tell my patient? Now you actually have a number, and I think that's where the personalized medicine really kind of changes the dynamic as far as treatment.
Yes, in my discussions with patients, I think that actually having a real number to focus on instead of saying, well, your risk is about 15% for T3 and 0, I mean, it does make the discussion of what's your risk of recurrence, what's the potential benefit of giving the treatment with 5-FU or fluoropyrimidine alone or with Folfox, that it can really contextualize that much more effectively.
When people ask me, should we be doing this genomic assay on every single, stage 2 colon cancer? Right. I think, I always revert back to some of these clinical utility studies. I think, very powerful was the prospective Mayo Clinic study, showing that they changed what they were going to do on the therapeutic side, up to 45% of the time. And, to me, I think as a pathologist, if I'm analyzing a tumor, any solid tumor, and I know there's a test out there that's going to change what the therapy is going to be 45% of the time, to me that's a test that should be included as part of the tumor analysis. And so to me, I just see it as complementary. I don't see it as taking away what I do analyzing the tumor under the microscope, but I think everything kind of plays together, and I think a genomic analysis or the biology of the tumor really should be included on that report, and I think the prospective clinical utility studies seem to support that.
Well, I couldn't say that any better, so I'd like to thank you, Dr. Wheeler and Dr. Nagle, for this great discussion on the Oncotype DX colon cancer assay and how we use it in the clinic.
You're welcome.
Thank you.